At 32 weeks, pregnant with my third baby, my blood pressure spiked and I started seeing spots. I knew immediately what it was: preeclampsia. And I knew it was serious. Today, I'm explaining the most common pregnancy complications: preeclampsia, gestational diabetes, and placenta problems. What they are, how to recognize them, and what happens if you're diagnosed. Because knowledge is power, and early detection can save lives. Hey everyone, I'm Diana, and welcome back to Sweet Pregnant. I'm a doctor specializing in women's health, and I'm a mom of 3. And here's what I want to say up front. Most pregnancies are healthy and uncomplicated. The majority of women will never experience any of these conditions. And when complications happen, they can be scary, especially if you don't understand what's going on. So today, I'm breaking down the 3 most common pregnancy complications. Not to scare you, but to educate you. Because if you know the warning signs, you can get help early. And early intervention makes all the difference. Let's start with preeclampsia. Preeclampsia is a serious condition that affects about 5 to 8% of pregnancies. It's characterized by high blood pressure and often protein in the urine, usually developing after 20 weeks of pregnancy. What causes preeclampsia? We don't fully understand the cause, but it's related to problems with the placenta and blood vessels. The placenta doesn't implant properly or doesn't develop adequate blood supply, which triggers a response in your body that raises your blood pressure. Who's at higher risk? First-time moms, women over 35, women with pre-existing high blood pressure, diabetes, or kidney disease. Women carrying multiples, twins, triplets. Women with a family history of preeclampsia. Women with obesity. Women who had preeclampsia in a previous pregnancy. But it can happen to anyone, even women with no risk factors. What are the symptoms? High blood pressure. Usually the first sign, which is why they check your blood pressure at every prenatal appointment. Protein in urine. Your doctor tests for this. Severe headaches that don't respond to Tylenol and don't go away. Vision changes. Seeing spots, flashing lights, blurry vision, or temporary vision loss. Upper abdominal pain, usually on the right side under the ribs. This indicates liver involvement. Nausea or vomiting, especially in the 2nd or 3rd trimester when morning sickness should be gone. Decreased urination, peeing less than usual. Sudden severe swelling, especially in the face and hands, not just the ankles. Shortness of breath could indicate fluid in the lungs. If you have these symptoms, call your doctor immediately. Preeclampsia can progress rapidly. What seems mild can become severe within hours or days. My experience. At 32 weeks with my 3rd baby, I noticed my hands were puffy and my rings felt tight. Then I got a headache that wouldn't go away. I checked my blood pressure at home and it was 160/100. I called my doctor and went straight to the hospital. They confirmed preeclampsia. My baby was monitored closely and I was put on bed rest and medication. Fortunately, we made it to 37 weeks before they induced labor. My baby was healthy, but it was a scary few weeks. How is preeclampsia treated? The only cure is delivering the baby. If you're close to term, 37 weeks or later, your doctor will likely induce labor or perform a C-section. If you're earlier in pregnancy, they'll try to manage it with bed rest, either at home or in the hospital. Blood pressure medication to keep your pressure controlled. Monitoring, frequent doctor visits, ultrasounds, and non-stress tests to check on the baby. Corticosteroids. If early delivery is likely, these help the baby's lungs mature faster. If preeclampsia becomes severe, very high blood pressure, organ damage, or the baby is in distress, they'll deliver immediately, even if it means a premature baby. A premature baby is better than a dead baby or a dead mother. Eclampsia. If preeclampsia is untreated, it can progress to eclampsia, which involves seizures. This is a medical emergency. HELP syndrome. This is a severe variant of preeclampsia involving liver and blood clotting problems. It's life-threatening and requires immediate delivery. Postpartum preeclampsia. Preeclampsia can also develop after delivery, usually within the first week postpartum. If you have severe headaches, vision changes, or upper abdominal pain after giving birth, call your doctor immediately. Gestational diabetes, GD, is high blood sugar that develops during pregnancy. It affects about 6 to 9% of pregnancies in the United States. What causes gestational diabetes? During pregnancy, your placenta produces hormones that make your cells more resistant to insulin. For most women, the pancreas compensates by producing more insulin. But for some women, the pancreas can't keep up and blood sugar rises. Who's at higher risk? Women over 25, especially over 35. Women with obesity or overweight. Women with a family history of diabetes. Women who had gestational diabetes in a previous pregnancy. Certain ethnic groups, Hispanic, African American, Native American, Asian, Pacific Islander. Women with PCOS, polycystic ovary syndrome. But again, it can happen to anyone. How is it diagnosed? Between 24 and 28 weeks, you'll have a glucose screening test. You drink a sweet glucose drink, then your blood sugar is tested 1 hour later. If your blood sugar is high, you'll do a 3-hour glucose tolerance test to confirm the diagnosis. I had gestational diabetes with my third baby. I failed the 1-hour test and then failed the 3-hour test. I was diagnosed at 26 weeks. Why does gestational diabetes matter? If your blood sugar is too high, it can cause problems. For the baby, macrosomia, a very large baby, which can make delivery difficult and increase the risk of birth injuries or C-section. Low blood sugar after birth, hypoglycemia. Increased risk of obesity and type 2 diabetes later in life. Rarely, stillbirth if blood sugar is very poorly controlled. For you, higher risk of preeclampsia. Increased risk of needing a C-section. Higher chance of developing type 2 diabetes later in life. About 50% of women with GD develop diabetes within 10 years. How is gestational diabetes treated? Diet. This is the first line of treatment. You'll meet with a nutritionist who will teach you about carb counting and balanced meals. You'll eat smaller, more frequent meals and limit simple carbs and sugar. Focus on protein, healthy fats, vegetables, and complex carbs in controlled portions. Exercise. Regular physical activity helps your body use insulin more effectively. Walking after meals is particularly helpful for lowering blood sugar. Blood sugar monitoring. You'll check your blood sugar 4 times a day, fasting, when you wake up, and 1 or 2 hours after each meal. This is annoying, but necessary. You'll prick your finger and use a glucose meter. I did this for 11 weeks. It became routine, but I was always relieved when a reading was in range. Medication. If diet and exercise don't control your blood sugar, you'll need medication. Usually insulin injections or sometimes an oral medication like metformin. About 15 to 30% of women with GD need medication. Increased monitoring. You'll have more frequent doctor visits and ultrasounds to monitor the baby's growth. You might have non-stress tests in the 3rd trimester to make sure the baby is doing well. Delivery. Many doctors recommend inducing labor between 39 and 40 weeks if you have gestational diabetes to reduce the risk of complications. Some doctors will let you go to your due date if your blood sugar is well controlled. After delivery, gestational diabetes usually resolves immediately after the placenta is delivered. But you'll have a glucose test at 6 to 12 weeks postpartum to make sure your blood sugar has returned to normal. And you should be screened for diabetes regularly for the rest of your life. My experience with GD. I was overwhelmed at first, checking my blood sugar, counting carbs, worrying about every meal. But I got into a routine. I learned which foods worked for my body and which spiked my sugar. My blood sugar stayed controlled with diet and exercise. I never needed medication. My baby was born healthy at 38 weeks, and my blood sugar went back to normal immediately after delivery. It was manageable, just annoying. The placenta is the organ that nourishes your baby during pregnancy. Normally, it attaches to the upper part of the uterus, but sometimes it attaches lower, partially or completely covering the cervix. This is called placenta previa. How common is it? About 1 in 200 pregnancies. What causes it? We don't always know, but risk factors include previous C-sections or uterine surgery. Scar tissue can affect where the placenta implants. Multiple pregnancies, twins, triplets. Being over 35, smoking. Previous placenta previa. How is it diagnosed? Usually during the anatomy scan ultrasound at 18 to 20 weeks. If the placenta looks low, they'll recheck it later in pregnancy because the placenta often moves up as the uterus grows. Types of placenta previa. Complete previa. The placenta completely covers the cervix. This requires a C-section. Partial previa. The placenta partially covers the cervix. Might require a C-section depending on location. Marginal previa. The placenta is right at the edge of the cervix. Vaginal birth might be possible. Low-lying placenta. The placenta is close to the cervix but not covering it. Usually resolves by delivery. What are the symptoms? The main symptom is painless vaginal bleeding, usually in the 2nd or 3rd trimester. The bleeding can be light or heavy. It might stop and then start again. If you have any vaginal bleeding, call your doctor immediately. How is placenta previa managed? If diagnosed early and you're not bleeding, you'll be monitored closely with ultrasounds. If you have bleeding, you might be put on bed rest or pelvic rest. No sex, no exercise that could trigger bleeding. If bleeding is severe, you might be hospitalized. Delivery. If the placenta is still covering the cervix at term, you'll have a scheduled C-section, usually around 37 to 38 weeks. If the placenta moves up and is no longer covering the cervix, vaginal birth might be possible. Risks. Heavy bleeding during pregnancy or delivery. Premature birth if bleeding triggers early labor. Placenta accreta, see below. Placental abruption is when the placenta separates from the uterine wall before delivery. This is an emergency because the baby loses oxygen and nutrients, and the mother can bleed heavily. How common is it? About 1 in 100 pregnancies. What causes it? Often we don't know, but risk factors include high blood pressure or preeclampsia, abdominal trauma, car accident, fall, smoking or drug use, especially cocaine, previous placental abruption, being over 35, carrying multiples. What are the symptoms? Vaginal bleeding can be light or heavy. Sometimes there's no visible bleeding if the blood is trapped behind the placenta. Severe, constant abdominal pain. Different from contractions, which come and go. This pain is continuous. Back pain. Uterine tenderness. Your belly feels hard and tender. Frequent contractions. Your uterus might contract repeatedly. If you have these symptoms, call 911 or go to the hospital immediately. Placental abruption is a medical emergency. How is it treated? If the abruption is small and the baby is doing well, you might be monitored closely in the hospital. If the abruption is large or the baby is in distress, you'll have an emergency C-section. There's no way to reattach the placenta. Delivery is the only solution. Placenta accreta is when the placenta grows too deeply into the uterine wall and doesn't detach properly after delivery. This is rare but serious, affecting about 1 in 500 to 1 in 2,000 pregnancies. Why does it happen? Usually because of scar tissue from previous C-sections or uterine surgery. The placenta implants into the scar and grows abnormally deep. Risk factors. Previous C-sections. Risk increases with each C-section. Placenta previa combined with a previous C-section. How is it diagnosed? Usually suspected on ultrasound and confirmed with MRI. If you have a history of C-sections and placenta previa, your doctor will watch for this closely. What happens if you have placenta accreta? You'll have a planned C-section, usually around 34 to 37 weeks. The delivery will be done by a specialized surgical team, often in a hospital with a high-level NICU. After the baby is delivered, the doctor tries to remove the placenta. If the placenta won't detach, a hysterectomy, removal of the uterus, is often necessary to stop life-threatening bleeding. This is devastating for women who wanted more children, but it can be life-saving. Here's what I want you to take away from this video. Most pregnancies are healthy and uncomplicated. The majority of women will never experience any of these conditions, but complications can happen, and knowing the warning signs can save lives. Preeclampsia, high blood pressure, severe headaches, vision changes, upper abdominal pain, sudden severe swelling. Call your doctor immediately if you have these symptoms. Gestational diabetes, diagnosed with a glucose test between 24 and 28 weeks. Managed with diet, exercise, blood sugar monitoring, and sometimes medication. Usually resolves after delivery, but increases your risk of diabetes later in life. Placenta previa, painless vaginal bleeding in the second or third trimester. Managed with monitoring and often requires a C-section if the placenta doesn't move up. Placental abruption, severe, constant abdominal pain, and vaginal bleeding. This is a medical emergency. Call 911. Placenta accreta, rare but serious. Associated with previous C-sections and placenta previa. Requires specialized delivery and may require hysterectomy. Attend all your prenatal appointments. So many of these conditions are detected through routine monitoring, blood pressure checks, urine tests, ultrasounds, glucose screening. Don't skip appointments. Trust your instincts. If something feels wrong, call your doctor. Don't worry about bothering them or being dramatic. Early detection and intervention save lives. If you're diagnosed with a complication, it's scary, I know, but these conditions are manageable with proper medical care. Follow your doctor's recommendations, monitor yourself, and know that most women with these conditions go on to deliver healthy babies. If this video helped you understand pregnancy complications better, hit that subscribe button. My next video is about sleep training methods and how to help your baby sleep through the night. Drop a comment. Have you experienced any pregnancy complications, or are you worried about them? Knowledge is power. Stay informed, stay vigilant, and take care of yourself. I'll see you in the next one.